All right, ladies and gentlemen, for any of you who have not met Dr. Phillips yet on our MD Roundtable, he is our Associate Medical Director. He's kind of Dr. Frame's right-hand guy to give him help here, because being a medical director for a paramedic program nowadays is pretty much a full-time job for part-time people. And so Dr. Phillips graciously has stepped in to help. He is not just our medical director, but he is medical director for the EMS there at Weatherford, which is Parker County, which is just west of Fort Worth. And he is also an ER physician, a prior paramedic, ex-military. What did I miss, Dr. Phillips?
Also for Shackelford County now.
That's right. I forgot. You are the medical director for Shackelford County EMS up in Albany, north of Abilene. So thank you for coming tonight. It looks like we have a wonderful topic that I don't think any of our docs have actually touched on yet in all the years we've been doing the MD Roundtable. So that having been said, I'm going to hit security here and lock the meeting now and turn it over to you, sir.
All right. Well, first off, I already noticed that I already screwed up the title slide, because I got into putting all this together because you had it as one topic, and it is way too much for one night. I already keep you guys over every time that I talk anyway, so I decided that we'd just do pediatric dehydration tonight. We'll do sepsis the next time that we get together and talk. Just understand that the title slide is not quite accurate. So let me get so that we're actually moving here. Okay, so first off, volume depletion versus dehydration. First off, these terms get thrown around a lot, and so we'll tell you that they are actually two different things. Volume depletion is this reduction of the effective circulating volume in the intravascular space, whereas dehydration, you have a loss of free water more than a loss of sodium. So there is a little bit of a difference between them. However, I'll just tell you that usually they're used interchangeably. You're not going to be able to tell the difference between them in the field. So I would not even bother trying to differentiate between those. Either one is fine. Believe it or not, they actually code the same on our side of stuff. So don't worry about that. But just if you want to, sound a little more educated when you're talking with somebody, if you are more exact, you can throw out one definition versus the other, and sound a little bit smarter than I am. So let's talk about the etiology. First off, there are a lot of different things, but we're going to break it down into three different areas. There's increased or decreased intake. So in other words, you're not drinking enough. And this probably is what we see more than anything as far as the young kids go. They end up getting something that irritates their mouth, and they just don't drink as much. The next is that they're putting out too much. So most of the time, this is actually vomiting and diarrhea. This is probably overall, because of the ages and everything, this is what we see more than anything is due to vomiting and diarrhea. Occasionally, diuresis, will touch on that very, very briefly. And then increased insensible losses. So this is when we think about the kids this time of year in Texas that have been out playing and they haven't been drinking water and they get dehydrated. That's what we're talking about. And so one extreme form of that would be heat exhaustion and heat stroke. So vomiting. I do not expect you to be able to list everything that's on here. The main reason that I put this list up here is to give you an idea of the just sheer number of different things that can give vomiting in kids. But I underlined and bold-faced a couple of things there, and I want you to kind of keep those in the back of your mind. Number one, DKA. So kids, when they get DKA, diabetic ketoacidosis, those ketones and those high numbers will make them vomit. So will that acidosis. So that just makes everything so much worse. So you got to think about DKA if you got these kids that are throwing up. The next one is congenital adrenal hyperplasia. Now you're probably going, wow, that's a mouthful. And it is. but I'll tell you that this is something that, Jane, I don't know if you were still coming to the GTAC meetings around 2006, 2008, somewhere in that time frame. But it was right after the EpiPen law came into effect. We had some folks from the congenital adrenal hyperplasia group that came in wanting every ambulance in the state of Texas to carry cortisone. And that was for this particular problem.
I remember that.
And yeah, congenital adrenal hyperplasia is a rare disorder. At the same time, anaphylaxis is considered to be a rare disorder as well because of the incidence of it. It just doesn't happen very often. But congenital adrenal hyperplasia, for the most part, these kids, their parents already know that they have this. So I would tell you that, I've fallen victim to it as well. I want to be the smartest person and everything. If a parent comes up and tells you that their kid has one of these rare disorders of some sort, look at them and say with all sincerity, okay, you are the expert in this. I don't know what to do exactly. You tell me what I need to do for your kid. This is something that if you can get over this hurdle, anytime that you have a kid that has one of these rare conditions, I don't care what it is, kids that are on, pumps with medicines on a chronic basis because of heart problems, or if they have some kind of a rare birth defect, the parents are going to know so much more than you ever will about it. I don't mean that to slight you in the least, but take those parents' advice. If they tell you that their kid needs a steroid, give them a steroid. For congenital adrenal hyperplasia, steroid is the treatment. So keep that in mind. If a parent tells you that their kid has something strange, listen to them, okay? So diarrhea, we don't have as long of a list, but you notice that congenital adrenal hyperplasia is on there as well. Okay, and it should be hyperplasia, not hypo. So that one can give you either vomiting or diarrhea or both, and both of them can lead to a lot of electrolyte problems. So once again, I don't expect even if I'm in the field to be able to tell you what's causing these things. More than anything, I want you to understand that there can be a lot of different reasons for this. And for the most part, they're simple sort of things that's related to viral infections, maybe sometimes bacterial, even parasitic infections. So gastroenteritis is probably your most common reason, but keep in mind that there may be these other things that are going on as well. So increased output that's not vomiting or diarrhea. So once again, we're talking about diuretics sometimes. Renal tubular acidosis is RTA. High output renal failure, these are things such as a kid that has strep throat and then they develop a glomerulonephritis as a result of that. They tend to urinate a lot. It's called, actually another term for it is nephrotic syndrome. Once again, there is no way that you're going to diagnose these things in the field with what we have available to us. And it doesn't matter if you have the smartest emergency physician in the world that is sitting there in the rig with you. Other than hemorrhage, they're not going to diagnose these things. So other causes, the biggest thing that we see in the very young is poor oral intake. So for whatever reason, the classic is that they have sores in their mouth that are causing them to not be able to eat or drink. But then again, we also have the things such as fever, sweating. When kids get sick, they lose a lot of moisture in their breath, especially trying to get rid of fever. So they're sweating, but they're also losing more water in their breath. So let's take a check right here. Anybody have any questions up to this point? Remember that you can use the chat to throw things out there too.
Or you can unmute your microphone quickly and then remute. Some are saying, no, sir, no, sir.
Okay. So let me move that window off there. So epidemiology. first off, this is really, really common in the United States. And you see the numbers there, 30 million kids a year, about 1.5 million will present for care, 200,000 hospitalizations, and 300 kids die every year from volume depletion of one sort. And that's in the United States alone. Keep in mind that the younger kids are more susceptible. And if we treat it, the prognosis is great for these kids. Amy, excellent question there. What's the best steroid to give to a kid with congenital adrenal hyperplasia? I'll tell you that first off, we'll back up just a little bit. And Jane, you may remember when these people came to GTAC, they all said that for the most part, they already have the steroid. They have a kit. They usually have been trained as parents how to give this. But in the case of the woman that was coming to tug at her heartstrings, she had a child that had had 2 episodes of this, and she could not bring herself to give this to her child. So a lot of times they're going to have it. Frankly, it's going to usually be hydrocortisone. However, I'll tell you that any of the steroids will work. I'm a big fan of dexamethasone, hydrocortisone, dexamethasone. Both of them are long acting. They work really well. So, either one of those will work. If you're in an ambulance and you only have Solumedrol, give it. Okay. You're not going to go wrong by giving the wrong steroid to these kids. There may be one that's preferred, but if you don't have it, you don't have it. And any steroid is going to be your best bet. So, you may need to call your medical control and let them know and get a proper dosing. And actually, okay, this may get some medical directors upset. I would tell you that if you're in my system and you get one of these kids, call the children's hospital. Don't call the local hospital for directions on what to give. Call the pediatric facility and just say, I have a child that has congenital adrenal hyperplasia. The parents are requesting a steroid. This is what I have. What can I give? And they'll give you directions from there. So, and Kara, excellent question. I would tell you that that's where I'm going to have you call and ask the pediatric folks, because this is a rare condition once again. So we just don't see it. So back to epidemiology. So morbidity and mortality is based on the degree of dehydration and the underlying cause. Keep in mind that especially if these kids are really, really severely dehydrated, they are prone to actually have cardiovascular collapse. If they're hyponatremic, they may have seizures. And if you don't do the right treatment for them, and it's not really that difficult, but if you do the wrong things, you can actually cause morbidity and mortality. That's what M&M stands for. And iatrogenic means that we caused it. So we need to keep those things in mind. So when these kids present to us, when we get a call that says, you've got a kid that's throwing up, the biggest thing that I want you to do is to take a good history and physical. You don't have labs, you're not going to be able to get a final diagnosis. There is one lab, though, that is really important that you check, and we'll come to that in a second. But the really big part of this is recognizing when these kids are moderate to severely ill and starting the proper treatment for them. Okay, you can see the severity. It's mild, moderate, or severe. Okay, it's not that difficult to do. So history, really important part, especially with children, is, okay, a week ago, what was your baby taking as far as fluids? Were they taking 2 ounces at a feeding and feeding, 4 times a day, 6 times a day, 8 times a day? Were they taking 8 ounces at a feeding? And, so those are some important things. Okay, well, now that we know a week ago what they were doing that was normal, what have they had today? So those are some important questions. Are they having a lot of diarrhea? How many times? If they're vomiting, is it projectile? Now, when we say projectile, parents mean that it comes out of their mouth. When we say projectile, the way that I've heard it described from a pediatrician was, if you're holding your child on your shoulder and they vomit over your shoulder, do they get any of it on you? If they don't get any on you, that's projectile. So, you know, and it's hard because the parents, of course, are very biased and they're scared. And so I understand that. But just keep in mind that we need to be the calm in the storm, and we need to slow the things down. How many wet diapers have they had today? That's a really important question in babies, and their activity level. Usually you're going to be able to see, and it's usually pretty obvious. Could they have gotten a hold of anything? Have they been out in the sun today? Have they been out playing? Have they been ill? You know, all the usual things. And then this is a really important one. So 3-4 days ago, how much did they weigh? You know, a week ago, how much did they weigh? The last time that the child was weighed, what did they weigh? Those are some important things that you need to get. Obviously, we don't carry scales, so we're not going to weigh these kids, but you can usually look at them, and that's an important piece when you get to the hospital with these kids, to be able to say, you know, the kid weighed 15 kilograms a week ago when they went to their doctor's office for a well child check. So those are some important things to keep in mind. Nice one, Wayne. I like that. The Exorcist. Yeah, that's an extreme form of projectile vomiting, but I like that. Maybe I should have given this lecture closer to Halloween. Physical examination. So there's a reference down here as well that you don't necessarily have to read, but it's actually a good one for you to read. And it says that the most likely things for you to see and pick up to recognize 5% or more dehydration: abnormal cap refill, abnormal skin turgor, and abnormal respiratory pattern. And we're going to go over that in great detail in just a second. But the other quote from that same article: historical points in laboratory tests have only modest utility for assessing dehydration. Understand that the lab tests lag behind. So just because a kid looks severely dehydrated to you, their labs may look pretty normal. Okay. So the important part is that you still have to base it on your physical examination. So here's a table. I highlighted in yellow there the things that are those three main factors: breathing, skin turgor, and capillary refill. But if you'll notice, there's some other things that I think are kind of important that you need to kind of pick up on. First off, their mental status, and especially with an infant, sometimes it can be a little bit difficult until you get some experience. And once you have seen some kids that they're not crying when you walk in the room, they're not crying when you're examining them, something isn't right. And if you remember back to when we were talking about child abuse, that may be a sign of child abuse. But if the kid has been vomiting, and if you have some of these other findings on here, think about dehydration. It's always better to err on the side of treating a medical condition first, and then going back and picking up some of those other things. Heart rate. Now you noticed I highlight there tachycardia or bradycardia. Well, that doesn't really help, does it? Well, yeah, it does, because once again, we see normal to increase, and then one way or the other, abnormal. Okay. So just keep in mind that when they get severe, it can be really bad, and it may be that they're bradycardic. And then tears. I can't tell you how many times I've seen these kids that they're not making any tears. They're sitting there crying while you're doing your exam, but they are not making tears. Now, in a baby, they're going to make tears when they cry. It is not something that they control. It's not that they're faking their cry. It's that they're too dry to make tears. So keep that in mind. Okay. So this is actually an excellent chart. And I would tell you that, you know, and you can see it comes from Morbidity and Mortality Weekly Reports. That's what MMWR stands for. you can access this. This isn't something that it takes having a medical license or anything to access. You can get access to these things. And these are things that you need to have stuck away in your mind, and also have them stuck somewhere where you can reference them when you need them. There is nothing that says that you should not be able to reference something in a phone or some other text or some form when you're working. I don't know it all. I'll never know it all. I still look things up. So, considering our limitations in the field, really a finger stick blood sugar is one of the things that we really, really need to always think about doing on these kids, because the old maxim, keep them warm and keep them sweet, okay? That applies to newborns right after they're born, especially if they're crashing. It applies to the very sick kids. It applies to any kid. You got to keep them warm. You got to make sure that they're not hypoglycemic. DKA, you're not going to be able to do a whole lot about other than give them fluids, but you have got to give them glucose if they're hypoglycemic so that their brain continues to work. Any questions up to this point? I feel like I'm moving really fast through this. I don't mean to. So,
Crystal, I haven't seen you
rehydrate.
posting anywhere. Do you have any questions?
So rehydration. Now, some of this stuff I'm going to tell you, and I don't know how many of y'all are up to date with some of the stuff that's going on at the federal level, but currently right now, EMS is not paid if they don't transport. So all the community paramedicine programs, those are being done out of the goodness of people's hearts. And it's the right thing to do. And I'm glad that people are doing the right thing because it's the right thing to do. In the future, there is actually, there are committees at the federal level that are working to be able to get us paid for not necessarily transporting. And so I'm hoping that we're going to see some of these programs providing some more benefit besides just load and go. And so this is one of those areas that may actually be something that we can help out with. So current recommendations, and we're going to get into this a little bit different in a second as well, but we really should try oral rehydration if we can. Okay, now if they're severely dehydrated, obviously, no, we don't need to do that. If you got one of these kids that's not making tears and they're lethargic, don't try to give them something by mouth. But most of these other kids, we can try to give them something by mouth. And to be honest, the kids would prefer that. They don't want to get stuck with a needle. So oral antiemetics are great. And so almost every ambulance these days is carrying on Dancitron or Zofran. Keep in mind, can be used by taking the injectable version and squirting that in a kid's mouth. They can drink it. It works just as well. And a lot of hospitals will not keep tablets that are small enough for kids, or they won't carry the syrup, and they'll have you giving the IV formula orally. So it does work. Peripheral IV access. If you have to get it, you have to get it. And if they're really sick and you can't get a peripheral IV, go for interosseous. Okay. Now, obviously, for the physician side of stuff, they're talking about, should you do a central line and stuff? And you don't try that. I don't want to try that in kids. But Jonathan asked, any tips for IV placement for infants? Well, first off, it depends on what age you're looking at. However, you may need to look at a scalp vein if they're very young, but we're usually talking a month or so of age when you're doing that. For the most part, you can usually get a peripheral IV either at the AC or somewhere else, even in a foot. So, those are some options. And frankly, as a medical director, I would prefer that you look for an IV site before you go for an IO, because sometimes especially in very young children, you can end up causing a fracture with an IO placement. So I would much rather that you try to put an IV in first. Okay. I'm not recommending this. Okay. And if some of y'all heard Jane and I talking beforehand, there is a thing that actually does work in pediatrics that they call clysis therapy. Do not try this, okay? But they will actually place a fluid bolus subcutaneous on the back, okay? So, that's, just keep in mind that the children are very resilient. And so a lot of times you'll be able to find something in them. So Kara, the heel, I've never heard of putting an IV in the heel. It's a great place for you to be able to get a blood sample. If you're talking about putting an IO there, I've never seen that in the literature. If it's there, I'd love to see the literature. But once again, I don't think that I would necessarily want to put something there because it's so peripheral. And if you end up with an infection, then that turns into an osteomyelitis because of poor circulation. So, once again, if you have some reference, I would love to see that. And believe me, I love these questions. It's not a stupid question by any stretch because, and I think I may have shared with y'all that I went to a conference recently about crofab, the snake antivenom, and a PhD that was there started out his lecture with, I want you to ask questions because when you ask me questions, I learn. And this guy is probably 80 years old. There's no way I'm going to teach him anything, but the fact that he enjoys hearing questions and so, and it starts a dialogue. So if you guys have something like that, Kara, it's a good question. I can't say that I've ever heard of that, especially for an IO placement, if that's what you're referring to. But the proximal tibia is still where we're going to recommend in infants to put an IO. Frequently reassess. You got to look at these kids over and over and over. And then antidiarrheal medications, do not give them. If the parents say, yeah, he's been having diarrhea and I've got this Imodium or whatever, don't give it to him. Just and especially if you're in a community paramedicine program, tell the parents that that is not a recommended thing. Pediatrics does not recommend giving those. So let's give you something that is easy for you to learn, something that is easy for a parent to make up. And this has saved, they estimate, over 70 million lives since the 1970s when it was introduced. And this is oral rehydration solution from the World Health Organization. It's a simple recipe. A liter of water needs to be cleaned. Okay, so if they have to boil the water, okay? 2 tablespoons of sugar, and I underline the tablespoons so that you know that that's tablespoons and not teaspoons. And then either half a teaspoon of salt or a quarter teaspoon of salt and a quarter teaspoon of baking soda. For me, I'm easy to remember, just a liter of water, 2 tablespoons of sugar, and a half a teaspoon of salt. It's that simple. Now, some of the references that you may look at, we'll talk about adding a half a cup of fruit juice or something to it, but the American Academy of Pediatrics recommends against using juices for dehydration diarrhea. Now, let's see if anybody knows the answer to the question. Why? Why would they say don't use fruit juice for those? You can unmute your mic and.
It causes more diarrhea in some cases.
Exactly. How does it do that?
It's acidic and it irritates the intestines, the stomach.
Well, it's somewhat irritative, but more than anything, it's a huge sugar load, and that sugar load actually draws more water into the gut. So it'll actually worsen their volume depletion because now you're sucking this water into the gut, and then they get an osmotic diarrhea as a result of that. So excellent. Great. Thank you. So let's talk about mild dehydration. So a lot of times this can be followed up or can be managed as an outpatient, but they got to follow up with somebody. This is once again one of those places where I can see if you have a really engaged community paramedicine program, being able to say, okay, hey, we went and saw this kid, we talked to mom, we offered transport. She said, no, I'm okay, I can take care of this. But we need you to follow up in the next 2 days. Either that or you arrange somehow to get that kid and follow up. And a lot of times community paramedicine programs will work with primary care providers and can try to get these people seen within a time frame. So, it's an excellent use for community paramedicine. Most of the time in the ERs, all that I'm going to do is I'm going to give them oral rehydration. It works well for mild dehydration. And then I would tell you, though, that if there is any parental concern, just carry the kid. Just take the kid in, okay? Don't say, well, we got to get an IV, okay? If you're working in my system and you have a kid that fits the criteria for mild dehydration, let's go back to that slide and let's look at this. So you have this kid that's all in this left column. Everything really looks pretty normal, except that they're vomiting, okay? If you have a kid like that, it's okay. You don't have to put an IV in the kid, okay? And frankly, at the pediatric facilities, they're not going to either. So don't feel bad about that. So should have paid attention to the slide number there. So that's mild dehydration. Now with the moderate, a lot of times this can also be treated orally, but with a much larger volume. So we're talking 50 to 100 mLs per kilogram. So let's say that you have an 8-kilogram kid, a 16-pound child, you're looking at 1,600 cc's that this kid may need over 2 to 4 hours, with every 5 minutes getting 5 mLs. That's quite a bit. So you may be able, especially if you're going to anticipate having problems starting an IV, it may be easier to give them the oral than it is to start an IV. And if they're cooperative, I would still say that you're going to end up transporting this kid most times, but you may be able to just get the kid drinking some fluids in the back of the ambulance with some oral Zofran to be able to get them there. Now, let's talk about this 20 cc per kilo fluid bolus, okay? When I was a resident, we saw these kids pretty often, and we would say, yeah, give them a 20 cc per kilo bolus, then we would walk away. But I still remember one time with a really sick kid where the attending stood there and said, here's a 20 cc syringe, you give the fluid bolus. And I'm like, what? They said, you got an IV that's running there, pull up the fluid into the syringe, and then turn the stopcock and give that as a push, and then open it up, fill your syringe again, close the stopcock, and we literally gave a 20 cc per kilo bolus over a matter of about 2 to 3 minutes. So, if they're really sick, and probably more towards the severe side in this, keep in mind that fluid bolus does not necessarily have to run in over a certain time period. It is a bolus, and especially for a really sick kid, you need to give it to them. And once again, if you're in my system, I want you to transport these kids because I want to be sure that they're going to be able to tolerate oral fluids. And that's one of the things that we're going to do before we discharge these kids, is we're going to make sure that they're able to hold stuff down orally. So the severe. So a lot of times these kids are going to require more than 120 cc per kilo bolus. And I don't know if any of y'all are in the Dallas-Fort Worth area. I'll tell you that having worked 90 miles from Fort Worth and an outlying ER, Cook Children's Hospital did not want us giving more than one fluid bolus unless we were transporting that kid to them. And there's a lot of reasons for that. And I think that really has a lot of wisdom in that. And I still kind of follow that, even though I'm not necessarily working in that kind of a rural environment right now. But keep in mind, especially if you're giving more than 120 cc per kilo bolus, that kid needs to probably be at a children's hospital if possible. And if you're giving your third bolus and the kid is still not looking good, you need to start thinking about other reasons for this. Are they bleeding somewhere? Do they have sepsis? They may need vasopressors. Before you do that, call the children's hospital, get some help. Okay, there is no foul, there is no penalty for calling and asking a friend to help. And believe me, the pediatric people are your friends in these cases. Check the glucose. Always remember to check the glucose. Now, I don't know the services that you guys are in. I've actually gone away from D50 completely and D25 at Life Care in Parker County. We only carry D10. And the main reason for that is that there are a lot of problems with D50, and some of it's been related to supply chain issues. But D10 works for adults, it works for kids, it works for neonates, it works for every patient that you have. Whereas if you have D50, and I did work at one hospital that the night before I started there, they delivered a baby and the baby was hypoglycemic, and they only had D50 in their ER, which meant that they were going to have to dilute that down. So there's some issues with that. And if D50 extravasates, it causes necrotic area. So, there's some issues related to D50. And so for me, it's easier to just remember, hey, D10, especially for an adult, 1 cc per kilo is going to help everybody. It may work a little bit slower, but the patients also don't feel like they're intoxicated when they wake up from their hypoglycemic episodes. So, Kara, I see your question there. I think that really, first off, that is going to depend on a lot of factors as far as the question is whether or not to fly those kids. First off, understand that flying anybody, bringing a helicopter to a scene is an inherently dangerous thing. And I've heard police chiefs and fire chiefs that say, yeah, but driving is dangerous too. Yes, it is. And the statistics about air crashes, those don't apply to non-scheduled flights. Those only apply to scheduled airlines. You're not calling a scheduled airline. So there's some issues associated with that. And so keep in mind that you're endangering a lot of people along the route. You're endangering people in the helicopter. You're endangering people wherever you decide that they're going to pick up your patient, whether that be at the hospital helipad or at a scene. There are a lot of factors associated with that. And the question that I always ask is it really going to make a difference? Because the place where air medical makes a difference, really makes a difference, is time. Okay, so time critical stuff. And we can have a great talk sometime at a bar about how the golden hour came about and the myth of that. And that's a great topic for us to talk about sometime. The other place where air medical really has a place is in unstable spinal fractures. And that has to do with the fact that, believe it or not, it's a much smoother ride than in the back of an ambulance. That's the only reason. So those two are the only reasons that I ever advocate flying somebody, is when it's time critical or if they have an unstable spinal fracture. And so the question is, what is a helicopter crew going to be able to do that you cannot do in the back of your ambulance? And I understand they can get there faster. Okay. And I grant you that. But is it worth the risk? And so that's something where a lot of experience is going to have to kick in. And I understand that you may be uncomfortable with that patient, but I just have trouble seeing something as a critical need that you have to use, except when there's a cloud in the sky. And unfortunately, we hear those sort of critiques of air medical at times. You know, oh, there's a cloud in the sky, so they're not flying. So Wayne, yes, RSI. Once again, there are other alternatives in many cases to doing RSI or any kind of medication-assisted intubation. So there are some alternatives to those things, and I worry about people being very quick to put somebody down and breathe for them. It's one of those things that, especially as I've matured over the years, I've gotten to where I do it a lot less than I ever did when I was a resident. And there are a variety of reasons for that, BiPAP and CPAP being a big factor, but I just don't do it nearly as much as I used to. And so, you know, I would urge you to, you know, think through some of these scenarios. And this is where talking with your system medical director and getting some idea of where they stand on these things can really be influential. But I also, as a dispatcher, when I was a paramedic, sent an ambulance out to a call where a local air medical ambulance was taking off from a scene in clear weather and clipped a power line and then crashed to the ground and rolled back onto the same accident scene. So nobody was killed, but the flight medic and the flight nurse were injured because they were not secured yet in the aircraft like they should have been. So I just understand that I've been doing this now for 38 years, and I really am hesitant in a lot of cases unless I know for sure that it's going to make a difference. But they're excellent questions. And once again, this is where I would say that you need to sit down with your medical director and just say, okay, you know, let's talk about these things. It's not because I'm trying to pin you on an answer or anything. I just want to know what your thought process is, because we all want you to think critically. You know, I want my paramedics to think these things through ahead of time. And so it's excellent questions. So maintenance fluids and so I don't expect you to be able to pull this out of your head. Okay. Obviously, this is more for long distance transports like we're talking about, where it's an hour or so. But if you need to start giving some maintenance fluids, here's the way that you have to calculate this stuff. So for the first 10 kilograms or less, it's 100 mLs per kilogram per day divided into a day. Okay. And so that's 1,000 mLs per day if they're 10 kilos. For the next 10 to 20, the next 10 kilograms of body weight, it's 50 milligrams per kilogram per day. So once again, now we're maxing out at 1,500 mLs per day. And then over 20 kilograms, you add another 20 mLs per kilogram per day for each kilo over 20. So here's the example. Okay. So a 27 kilogram kid, for the first 20 kilos, 1,500 mLs. Stop right there. Take 7, okay, because that was for the first 20. Now 7 times 20 mLs per kilo is 140 mLs, 1,640 mLs per day. Divide that by 24. Your rate is 68.3 mLs per hour. Call it 70, okay? So this is something that if you're in one of these systems like CARA, where you're an hour away from the nearest hospital, this might be something for you to stick in the back of your mind to be able to say, okay, the kid's no longer throwing up. His vitals have stabilized some. We're transporting. We don't need to run lights and siren. It may be 2 hours for us to get there. Let's slow everything down. Here's the maintenance fluids. And, you know, when you get to that hospital and you say, yeah, we already gave 220 cc per kilo boluses, things seem to improve. We gave some D10. And now, you know, everything seems to be better. And I just put them on a maintenance rate of D5 half NS at 68. You know, believe me, that ER doctor is going to go, wow, you figured out all that? Yeah, we learned about it in school. You know, you're going to look good to that person. That's what I want. I want you to think, okay? Understand that my bottom line with all of this stuff is I want you to think. So antiemetics, let's talk about this, okay? So there's a couple of references, but the best one is from this Cochrane database of systemic reviews. And if you've never looked at this, it's an excellent resource. What they do is that they look for randomized controlled trials. They grade those trials in an area and tell you if it was good study, bad study, what the faults were, those sort of things. And then they compile more than one. They look at all of the trials in a particular area and they come up with, okay, what does the best evidence show? Well, in this case, the article is antiemetics for reducing vomiting related to acute gastroenteritis in children and adolescents. So the conclusion, okay, I highlighted and bolded some of this. Okay, that's not theirs. But so they say that a small number of trials showed some weak and unreliable evidence, but still some evidence that appeared to favor the use of Zofran, ondansetron, and metoclopramide, which is Reglan, over placebo to reduce the number of vomiting episodes due to gastroenteritis. Okay. So they also note, though, that there was an increased incidence of diarrhea with both of those groups, and they believe that that's because of the retention of fluids and toxins that would have been vomited out. So understand that there's some give and take on this, okay? But this is from 2006, and this is looking at probably 20 years worth of evidence. Zofran, just for reference, came onto the market when I was an intern in 1991. So it's not been around a long, long time. So the emergency medicine literature and even the pediatric emergency medicine literature supports giving a single dose of Zofran with rehydration for nausea and vomiting. Okay, but just keep in mind that doing that should not keep you from resuscitating a child. If they're severely or moderately sick, you need to take care of resuscitating that child before you say, okay, well, we're going to give you something by mouth so that you're not going to throw up anymore. Got to try to decide if they're in that situation where you have to do the resuscitation first. Got to get them the fluids. And big key, antidiarrheal agents are never recommended. So if it's caused by something else, whether that's DKA or sepsis, got to get the appropriate treatment. Now, all that we're going to be able to do is going to be fluids for the most part if it's DKA or sepsis. If they're hypoglycemic, getting them the sugar is going to be the big thing. So let's talk about Zofran. Here, I'm just going to go real quickly through the dosing on these. Okay, so 8 to 15 kilograms, 2 milligrams oral. Okay, and keep in mind you can give the IV solution orally. 16 to 30 kilos, 4 milligrams oral, or a maximum dose of 4 milligrams IV. And if they're over 30 kilos, you give them 8 milligrams oral or 4 milligrams IV. Keep in mind that 4 milligrams IV is the maximum dose for any age IV. Okay. So Brian asked, would the dosage change if given PO? Yes, it's right there. So the dose IV is always 0.15 milligrams per kilogram, up to a maximum of 4 milligrams IV. Oral, if they're under 16 kilograms, it's 2 milligrams. If they're over 30, it's 8 milligrams. So no, it's not silly. It's that I may not have gotten to that point in the slides yet. So, and keep in mind that the maximum dose oral is 8 milligram for any age. Reglan, okay. It's in the Cochrane review. Frankly, I use it in the ER, not very commonly, but I do use it in the ER, but I don't know of an ambulance service that is still carrying it. And if it is, then you need to talk to the medical director about what dosing to use, and that'll be in the pharmacopoeia for that service. So, questions up to this point? If not, let's get into a case. So, you're called to a private home, 31-month-old that has been vomiting and is lethargic, according to the mom. Keep in mind that that term means a lot of different things to different people. Child weighs about 34 pounds, according to the mother, and she says that he started throwing up yesterday and can't take anything, and anytime that the child does, he throws it up. Last wet diaper was over a day ago, but there's been no diarrhea and no fevers, no ill contacts. So, how many of y'all were here for the last one where we had spit and skid? Somebody want to start us out with giving us a serious diagnosis on this? You can unmute your microphones. So is this a first child? You know, I actually didn't think about that. In this case, sure, we'll make it a first child. So anybody want to venture on the 4-item differential diagnosis? Serious problem. What's a serious problem that this kid could have?
Two-year-old, he could have gotten into something and drank poison, household cleaner of some type.
Okay. So an ingestion. Perfect. Okay. What about a probable? What do you think that this kid really has? Gastroenteritis? I mean, that's certainly a possibility and a likely one. So real quick, we'll go over this. Spit and skid. SPIT is 4 items that are possible diagnoses. Okay. A serious diagnosis, a probable diagnosis, an interesting one, so something that's rare, and then a treatable diagnosis. So if we put ingestion for our serious one, probable is gastroenteritis. What's something that would be an interesting one? How about that congenital adrenal hyperplasia? Okay, might not have been diagnosed just yet, so that's a possibility. Treatable thing. How about got too hot, got overheated, and has had some mild heat exhaustion. So that's an example of a 4-item differential diagnosis. Okay, I do this because I want you thinking about all the possibilities. Okay, the interesting thing, the interesting diagnosis is also known as your rare thing. And the saying is, if you're on the plains of West Texas and you hear hoofbeats, you should think that you're going to see horses and not zebras. But you still need to think about the zebras because otherwise you won't recognize that black and white striped horse as it runs past you. Okay. The next part, skid. Let's take it one item at a time. Are they sick or not sick?
Yeah, that's kind of why I asked about if it's the first kid, but other than the last wet diaper being 24 hours ago, if it's a first kid, I know when we had our first kid, the kid coughed and oh my God, what are we gonna do?
Well, I'm not asking.
They're alive.
I'm not asking you as a kid's parent. I'm asking you as the paramedic that's on the scene. So, do you think right now, based on what I've given you, is this kid sick or not sick?
Just based solely on the wet diaper being 24 hours ago, sick.
Okay, and Bobby says sick. Joanna says sick. Okay, so what are some killer things that if we don't think about and treat these things that could kill this kid?
Good night.
Good night. Love you. So first thing that I think about is diabetic problem. So if they're hypoglycemic, that can kill somebody quickly. Okay. So that's one. The congenital adrenal hyperplasia. If they're severely dehydrated, as Amy says, absolutely, that can kill this kid quickly. Okay. So let's talk about the I, interventions. What do you want to do? That's what I stands for, is the interventions. So somebody tell me just some things that you want to do for this kid right now. I got fluids. PO, good. Zofran and PO, excellent. Okay. So let's move on to this. Okay, let's get some more information now. So here's your vital signs. So heart rate's 142, respirations are 32, and the BP is 72 systolic. Okay, in this age group, that's all that you're going to get. What do you think about those vitals? Are they normal or abnormal? 2-year-old. I'll tell you, 142 is high. Okay, respiratory rate of 32 is high. Capillary refill is 3 to 4 seconds. Skin turgor, recoil is at 4 seconds. And respirations are deep and rapid. So let's go back to slide 12 here. Where are we at on this? Okay, Joanna says severe. Everyone agree, disagree? Moderate to severe line. Well, that skin turgor was 4 seconds. And the capillary refill was somewhat prolonged as well. So yeah, I actually think that this kid is probably severely dehydrated. And especially with the deep and rapid respirations. So what do we want to do with this kid? Do we want to modify any of this stuff here? As far as the interventions, everyone said fluids and Zofran. Anything else that you want to do with this kid? What do we say were one of the killer diagnoses? Yeah, get a blood glucose. So this kid is ill, okay? Doesn't cry as you examine them. The eyes are also going to appear sunken. These are things that we would give you later on as well, and no tears are observed. So when you do the blood glucose, you get error. Most of the time, that means that it's too high. So the machine is not able to register that. So at this point, this kid most likely has new onset diabetes. Okay. So I purposely designed this case this way because I want you to start thinking about these things. Now, I'm seeing people saying diesel. Okay. Understand once again that once you get the fluid started, this is not something that you need to run red lights and sirens to the hospital. You're endangering a lot of lives, including that child, by doing that. Your best course of action in this case is going to be to get the IV in place, start the fluid boluses, give 1, maybe 2 while you're en route. Okay. Don't sit there and go, hey, let's stop and get a Starbucks on the way to the hospital. But this is not something where you need to risk everyone's life busting intersections. Okay, those days I hope are almost completely gone. One fire department that I used to work with, the fire chief actually went on a call with me riding in his car. We stopped at every light on the way to the call. The ambulance busted every intersection. We got there 2 minutes after they did. 2 minutes. 2 minutes really is not going to make that big of a deal. And this was not in a small response area. It was actually outside of town. So, just keep in mind that this is a time where you already have everything that needs to be done immediately for this kid. The big thing is a fluid resuscitation. If you get the IV in place, even if you have to do an IO, you're giving the kid most of the definitive treatment. Yes, he's going to need insulin. You don't have that. But 20 minutes to get to the hospital versus 15 or 10 is not going to make a difference. Okay. So this is not the time to start saying we got to floorboard it to the hospital. Okay. So case 2, now this one is going to be more like a case that you're going to get a question on for National Registry. Okay. So we're going to still discuss it somewhat, but you got a 4-year-old female, has been having vomiting and diarrhea for 2 days, was at the doctor's office 3 weeks ago, weighed 43 pounds, and it was a well child check. And there are no other ill kids at home. PMD is negative, no meds, no allergies. Vital signs. And here's your cap refill. So let me take you back to slide 12 so that you can see that one. And then we'll go back to the case. So, anybody have any questions at this point on this one? So, given the patient that was described, what is your most appropriate treatment plan? Okay, wait to answer until all the options are given. IV bolus and transport, Reglan 5 milligrams IM and leave, Zofran 8 milligrams IV and transport, oral Zofran and leave at the scene with the mother, or transport to the pediatric hospital in the next county. Okay, I got an A. You know, at some point we need to get poll everywhere and start doing this where you have to lock in your answer and nobody sees it. So yeah, A is the proper answer. Now, the one thing that I want to point out to you guys, okay, as you're preparing for registry or for any examination, is a lot of times they're going to do what I did with these options on, we call these distractors, A, B, C, D, E, or distractors. If you look, those are in alphabetical order, okay? That's the right way to construct one of these questions, is to put those distractors in alphabetical order, and also roughly they're all the same length, okay? So visually, they're pretty close to the same length. Now, the one thing that I didn't do is I really should have made it so that each of those could somewhat be plausible, but keep that in mind, and that's one of the reasons why those exams are so difficult, is that they are supposed to be that every one of those options should sound somewhat plausible. So anybody have a problem with 8 milligrams of Zofran? You can unmute your mic.
Yeah, for IV, it's max 4 milligrams.
Exactly. So how about transporting to the pediatric hospital in the next county? I would say that this is not something that necessarily requires a pediatric hospital just based on this. Do you think that this was a mild, moderate, or severe dehydration based on the case that was given in a 4-year-old? Yeah, I would say moderate. I agree with Bobby. How about the Reglan, metoclopramide? Yeah, it's not really used anymore, and to give an IM is not really the best thing to do. There are some drugs where it is appropriate, epinephrine for anaphylaxis, for example, but to give an IM dose of the medicine and then leave, that's not appropriate. And yes, you got to be sure that they can keep the fluids down. So yeah, there, if we had worded it where, yeah, you're going to have community paramedicine come and see them, okay, then that might be appropriate. But for this question, I agree. So what questions do you guys have about this at this point? I know it was not that clear. And keep in mind that I do like your questions. So Jane, can we share that slide 12 with them? I can get that to you as a separate thing, a PDF or something.
Yeah, I'll see where I can put it. I can probably share it either in the student forum or somewhere.
Yeah,
Plus,
and
this
what I'll do is
video will be shared inside the MD Roundtable blog as well.
Yeah, and if you look at the MD Roundtable blog, it has the reference for it right down there at the bottom of the chart. I stole it. I didn't come up with it, so plagiarism is good as long as you acknowledge your resources.
There you go. There you go. As long as you give your resources and nobody.
Yeah.
Okay.
Yeah, that's why I said I didn't come up with it.
It looks like everybody's been pretty well participating, so I don't think I have to pick on anybody, except for maybe you, Chris Brooks. I don't see you chiming in here much. Are you still here? Yeah, I saw you chiming in.
Yeah, he answered.
Yeah, I see up there. All right. Any more questions? You can unmute your microphone. Now's your chance. Chris said I'm here and taking notes.
Yep.
All right.
Once again, I like having questions. Send them to me even. That's fine. I don't mind that at all.